A yellow root sits in the spice aisle of every grocery store in America that traditional healers in India prescribed for joint pain, inflammation, and tissue repair for over 3,000 years. Surgeons in ancient Ayurvedic practice applied it to wounds before closing them. Warriors rubbed it into injuries sustained in battle. Elderly patients with swollen, painful joints drank it in warm milk every evening and woke up able to move in ways they could not the night before. Frank Miller here with Heritage Garden Wisdom, and that root is not hidden. You have seen it your entire life. The problem is not that it disappeared. The problem is that you were never told what it actually does. And the difference between knowing turmeric as a curry spice and knowing turmeric as one of the most rigorously studied anti-inflammatory compounds in modern pharmacological research is a difference worth approximately $30 billion per year to the pharmaceutical industry that sells you joint pain medication instead. But turmeric is only the first layer. Beneath it is a second plant, older, less visible, with an evidence base that mainstream rheumatology finds genuinely difficult to address. A plant that clinical trials have found performs comparably to ibuprofen for osteoarthritis pain, with significantly fewer gastrointestinal side effects, and that you have almost certainly never been told to consider. The rheumatologist writing your prescription operates inside a system with no financial mechanism for directing you toward an unpatentable plant. When Western pharmacological research finally turned serious attention to turmeric in the late 20th century, it identified curcumin as the primary active compound. Early research confirmed remarkable anti-inflammatory activity, inhibiting the same nuclear factor kappa B pathway that represents one of the most important targets in modern anti-inflammatory drug development. The pharmaceutical industry's response was entirely predictable. Isolate curcumin, modify it slightly to create a patentable derivative, run clinical trials on the derivative, and build a drug around it. Multiple pharmaceutical companies invested in exactly this approach. Multiple patented curcumin derivatives have been developed and tested. None of them has produced a successful pharmaceutical product at the scale the initial research suggested was possible. The reason is bioavailability. Curcumin extracted from turmeric and administered in isolation is poorly absorbed. The body processes it rapidly, and it does not reach target tissues in therapeutic concentrations. Clinical trials of isolated curcumin have produced inconsistent results, partly because the molecule that looks powerful in laboratory conditions does not behave the same way inside a human body without the matrix of other compounds present in whole turmeric. The pharmaceutical industry spent decades and significant research investment discovering that it could not improve on a preparation that Ayurvedic medicine had optimized 3,000 years ago. Plant number 1, Curcuma longa, turmeric. The botanical name is Curcuma longa. Turmeric has been documented in Ayurvedic texts for at least 3,000 years. The Sushruta Samhita, one of the foundational Ayurvedic surgical texts compiled roughly 2,500 years ago, describes turmeric applications for wound healing, skin conditions, and inflammatory complaints. When both major foundational texts of a sophisticated medical tradition document the same plant for the same conditions across thousands of years, that consistency is clinically meaningful. Research supports that combining the piperine in black pepper with the curcumin in turmeric enhances curcumin absorption by up to 2,000%. One study showed that adding 20 milligrams of piperine to 2 grams of curcumin increased its absorption significantly. Piperine makes it easier for curcumin to pass through the intestinal wall and into your bloodstream, and may slow down the breakdown of curcumin by the liver, increasing its blood levels. Traditional golden milk preparations, turmeric in warm whole milk with black pepper and fat, had already solved the bioavailability problem empirically across centuries of clinical observation. Ayurvedic preparations combine turmeric with black pepper because piperine increases curcumin bioavailability by up to 2,000%, and they combine turmeric with fat because curcumin is fat-soluble and requires dietary fat for absorption. Plant number 2, Boswellia serrata, Indian frankincense. The botanical name is Boswellia serrata. The resin of the Boswellia tree, harvested by making incisions in the bark and collecting the dried exudate, appears in Ayurvedic texts as shalaki, used specifically for joint conditions, inflammatory swelling, and musculoskeletal pain. Boswellic acids, the primary active compounds in Boswellia resin, inhibit 5-lipooxygenase, the enzyme that produces leukotriene inflammatory mediators specifically involved in the inflammation of joint tissue in osteoarthritis and rheumatoid arthritis. This is a different inflammatory pathway than the one targeted by NSAIDs, which inhibit cyclooxygenase. The difference matters because 5-lipooxygenase inhibition does not carry the gastrointestinal risks associated with cyclooxygenase inhibition. A compound that reduces joint inflammation through a different pathway than NSAIDs without the gastrointestinal side effect profile would represent a significant clinical advance if it were a pharmaceutical product. It is not a pharmaceutical product. It is a tree resin that has been used in traditional medicine for 3,000 years and cannot be patented. A 2003 randomized, double-blind, placebo-controlled crossover study published in Phytomedicine examined Boswellia extract in osteoarthritis of the knee. The study found significant improvements in pain scores, walking distance, and knee flexion in the Boswellia group compared to placebo, with effects appearing within 4 weeks of treatment initiation. The treatment was well tolerated, with no significant adverse effects. A 2011 study published in the International Medical Sciences compared a specific Boswellia extract preparation to valdecoxib, a COX-2 inhibitor pharmaceutical that was subsequently withdrawn from the market due to cardiovascular safety concerns. The Boswellia preparation produced comparable pain reduction to the pharmaceutical at the end of the treatment period. The Boswellia treatment was not withdrawn from the market for cardiovascular safety concerns because it does not carry them. A 2014 meta-analysis published in PLOS ONE examined the totality of randomized controlled trial evidence for Boswellia in osteoarthritis and concluded there was significant evidence for clinically meaningful improvements in pain and function. Meta-analyses represent the highest level of evidence in clinical medicine. A positive meta-analysis for an intervention is the finding that drives treatment guideline changes when pharmaceutical companies produce it. Boswellia's positive meta-analysis has not driven treatment guideline changes because no pharmaceutical company has a financial interest in the guideline change it would drive. Joint disease is the leading cause of disability in the United States. Osteoarthritis affects over 32 million Americans. Long-term NSAID use is associated with gastrointestinal bleeding, cardiovascular risk, and kidney damage. Approximately 16,000 Americans annually die from NSAID-related gastrointestinal complications. Like this video, subscribe to Heritage Garden Wisdom, and comment below, are you using turmeric and Boswellia for joint pain or staying on NSAIDs? Frank reads every one.